Good morning, everybody. So welcome to this new session. I am Vinciane Rebourg from Beaujon Hospital in France, and I'm very pleased to share this session with my dear friend, Julia Mayerle from Munich. And we'll talk about autoimmune pancreatitis. So we will have a great talk, I'm sure of that, and we will begin just right now with Miroslav Zivazinovic. Why is follow-up of autoimmune pancreatitis important? So, Miroslav.
First of all, I would like to thank the organizers for invitation. It's a great privilege to be a part of this session and discuss autoimmune pancreatitis, that is a relatively new entity in the field of pancreatology. The first publication was already in 1961, but basically the proposal of the concept and the name was coined in 1995 when the Japanese colleagues published the first report. In the next 10 years, a lot of case series have been published, and in 2006, history criteria were also published when all the most important categories were emphasized, and this was a big help how we can diagnose autoimmune pancreatitis. The same history criteria emphasized that it is very important to exclude pancreatic and biliary cancer in all patients in whom autoimmune pancreatitis is suspected. In 2011, international consensus diagnostic criteria were published. We still use these criteria, as you know, and also in this guideline, it was emphasized that the goal is to safely diagnose autoimmune pancreatitis, but also avoid misdiagnosis of pancreatic cancer as autoimmune pancreatitis. So another very important result of the ICD-10 criteria was differentiation between different subtypes of autoimmune pancreatitis. Type 1, that is related to IgG4 related disease, type 2, that is not related to IgG4 disease, and if we cannot be sure, we talk about not otherwise specified type of autoimmune pancreatitis. 2 years ago, first European guideline on IgG4 related digestive disease were published, and again, we emphasized the role of pancreas and association between IgG4-related gastrointestinal disease and cancer. So when we read all these guidelines and emphasize this on cancer, it's obvious that the biggest fear of pancreatologists in this context is pancreatic cancer. We are afraid to miss it. And we know that the risk of cancer seems to be increased in patients in IgG4. There are some controversial results in the different studies. There are also studies who did not confirm association between that, but it seems that the risk is increased. So this is why it is important to exclude autoimmune pancreatitis in all patients with autoimmune pancreatitis, to exclude cancer, and also closely follow up these patients. In this study published last year, authors performed scoping review on pancreatic cancer in patients with AIP, and they identified in total 33 cases of pancreatic cancer, mostly in type 1 autoimmune pancreatitis. Some very important results from this study came out. First of all, they noticed that 1/3 of patients had synchronous occurrence of pancreatic cancer and autoimmune pancreatitis, and in 2/3 of patients, it was metachronous. And this another group, in metachronous group, the median period between diagnosis of autoimmune pancreatitis and diagnosis of pancreatic cancer was approximately 5.5 years. And most cancers occurred more than 2 years after autoimmune pancreatitis diagnosis. So it seems that it is not just important to exclude pancreatic cancer at the time of autoimmune pancreatitis, it is also important to follow these patients on yearly basis, at least because most of the cancers occurred more than 2 years after diagnosis. And if we are not sure, if we cannot exclude pancreatic cancer, it's absolutely acceptable to perform pancreatic surgery in these patients because the results clearly show that. It is easy to say, but it is not easy to differentiate between autoimmune pancreatitis and pancreatic cancer. And unfortunately, we don't have some important biomarkers on this topic. We know that CA19-9 is not ideal tumor marker, but European guidelines recommend to use it, but not despite of limited accuracy. Not alone, of course, we recommend to integrate the values of CA19-9 together with other second-level diagnostics. And from our own clinical experience, we can confirm that most of our patients with AIP have elevated CA19-9, but very rarely more than 100. So if the values of CA19-9 are very elevated, that means few hundred, especially few thousand, that is very, very suspected for pancreatic cancer. But just like I said, it should be put in the context and used together with other second-level diagnostics, especially imaging. So we know nowadays that typical imaging of autoimmune pancreatitis is a parenchymal enlargement, so-called sausage-like shape, peripancreatic edematous rim. And as you can see at these pictures, it is not difficult to diagnose autoimmune pancreatitis if we have so nice pictures and if there are no suspected cancer changes. Unfortunately, in real life, it is not easy, and quite often we have patients with atypical imaging. Studies shows that approximately 28 to 48 of all autoimmune pancreatitis patients can manifest as a focal pancreatic mass with pancreatic duct stricture. And unfortunately, this is exactly how patients with pancreatic cancer can appear. So it is also both diseases share some characteristics. They are more common in older patients. They can appear with painless jaundice. So it is challenging to differentiate these two conditions. Recently published meta-analysis showed that magnetic resonance imaging might be clinically more useful to evaluate patients with autoimmune pancreatitis. And of course, also computed tomography had a high specificity, but suboptimal sensitivity. So this is why we recommend that magnetic resonance imaging is a method of choice for diagnosis and follow-up of patients with autoimmune pancreatitis. And finally, when we start with the treatment, and we know that glucocorticoids are the cornerstone of the treatment of patients with autoimmune pancreatitis, it is extremely important that response to initial treatment is assessed at week 2 to 4 after the start of the treatment with clinical, biochemical markers and imaging. So if it is autoimmune pancreatitis, we expect that very quickly all changes will disappear. It's just a question, it will be partial or complete response, and vice versa. If something is worsening, this is probably cancer and should be operated as soon as possible. So we can conclude that risk of cancer development in patients with autoimmune pancreatitis seems to be increased, and we recommend lifelong surveillance in all patients with IgG4-related disease and autoimmune pancreatitis. So pancreatic cancer is the most important reason to follow up these patients, but this is not the only reason. We know that other organ involvement is one of the diagnostic criteria, and the most common other organ involvement are bile ducts. So it's IgG4-related cholangitis. What we have learned in the last 2 decades is that this is not just the most common manifestation, but also very important manifestation, because bile duct involvement is a risk factor for relapse in autoimmune pancreatitis. So we are particularly careful in these patients because we can expect that after the first treatment of glucocorticoids, it's a high risk for relapse. but also other organ can be involved. Our results and also other results in Europe, Japan and USA show that also kidney involvement is quite often, as well as vascular involvement, lung involvement. And it is important to emphasize that all other organ involvement also react very nicely on glucocorticoid treatment. Just like you can see on these pictures. On the left side is the before, and on the right side after the treatment. So after just a few weeks of treatment, we can expect a very nice improvement. It is important to emphasize that it is it's nice to work as a team in this group of patients. So this is not just work of pancreatologists. We must closely cooperate also with the nephrologists, pulmonologists, especially rheumatologists, because in that way, we can optimize the follow-up and the treatment of these patients. When we talk about autoimmune pancreatitis type 2, it is inflammatory bowel disease that is important as other organ involvement. Of course, I will not go deeply in this topic because after me, you will hear details about this topic. But there is another clinical condition that I would like to emphasize in this group of patients, and this is osteoporosis. Even 8 years ago, it was first systematic review and meta-analysis published showing that almost 25% of patients with chronic pancreatitis have developed osteoporosis, and almost 2/3 of the patients either osteoporosis or osteopenia. So also our results in Karolinska cohort show that more than half of the patients with chronic pancreatitis had low bone mineral density. And surprisingly, 44% of these patients already experienced fracture. So this is why this is very important from the clinical point of view. We were not satisfied because only 23% of patients in our historical cohort had DXA, but we are improving in this topic. So this is very important to check out bone mineral density in this group of patients because we treat them with glucocorticoids. And of course, the risk of osteoporosis and fracture is even higher. Of course, exocrine and endocrine insufficiency are the most common consequences of chronic pancreatitis, despite of its etiology. And especially in autoimmune pancreatitis, we noticed that both exocrine and endocrine insufficiency occurs quite common. I will not go deeply in this topic again because our Italian colleagues who just recently published this very nice systematic review will a little bit later explain this in the details, but just like we said that exocrine and endocrine insufficiency, it seems that it's just a matter of time. And in most of the patients, unfortunately, sooner or later, after some follow-up, it will develop. So what we know nowadays is that it is very challenging to differentiate autoimmune pancreatitis from pancreatic cancer. So the most important in these patients is to exclude cancer. So we highly recommend that the first checkout, the first control should be assessed at week 2 to 4 with the clinical, biochemical, and morphological parameters. So we expect that it will be very nice regress of the changes, and vice versa. If it's not improving, it's very dangerous. It's most probably pancreatic cancer. It seems that IgG4-related disease, and particularly autoimmune pancreatitis, may be associated with an increased risk of development of pancreatic cancer. So this is why we suggest lifelong surveillance in patients with IgG4-related disease and in all patients with autoimmune pancreatitis. We know that other organ involvement is common in autoimmune pancreatitis. It is also one of the diagnostic criteria. So it's important to diagnose and follow up. And if it is possible, do it absolutely as a multidisciplinary team approach. Other organ involvement, especially autoimmune cholangitis, is a risk factor for autoimmune relapse. So in these patients, a little bit closer follow-up is recommended. Low bone mineral density is common, and the risk for fracture is high among all patients with chronic pancreatitis, especially in patients with autoimmune pancreatitis treated with glucocorticoids. So be careful, and we recommend check out regularly bone mineral density in these patients. And finally, exocrine and endocrine insufficiency it displays quite often, even at the time of diagnosis or during the follow-up. So routine and regular control of exocrine and endocrine function is necessary in these patients. So it seems that we learned a lot in the last 27 years since the name of autoimmune pancreatitis was coined. Unfortunately, there are still a lot of areas of uncertainty. So this is very important, and I would really like to encourage all pancreatologists to create awareness of this rare clinical entity. It is definitely underdiagnosed, so it is important that we present our results to other colleagues from other gastroenterology area, from other colleagues in internal medicine. Rheumatologists already know about that, but also to the surgeons, primary care, everybody who are included in some contact with these patients. Because if we create an awareness, and especially if we participate in a multi-centric prospective studies that are ongoing right now, we will give a chance to improve our knowledge and to fill a knowledge gap on this topic. So once again, I would like to thank for invitation, and thank you very much for your attention.
So many thanks, Miroslav, for this very nice overview of all the complication and the reason why we have to follow this kind of patients. So I have some question, and there is some question from the audience too. I will begin regarding the risk of cancer. Of course, it's to distinguish pancreatic cancer and autoimmune pancreatitis, but regarding the follow-up, you said that we have to follow this kind of patient for cancer, but which recommendation would you propose? I mean, which kind of imaging, and what about the frequency? Every year, every 2 years? What would you propose?
Well, there is no consensus. Thank you for a question. There is no consensus so far. So in our center, we follow all patients once per year and include MR imaging and also serum nutritional panel. And of course, we take some time in the first contact with these patients to explain carefully what is the nature of disease. So all patients contact us immediately if they have some worrisome clinical features, weight loss, change in stool habits, or anything else. So we think that annual follow-up is feasible. There are not so many patients. Our cohort consists approximately 170 patients as a historical cohort, so it's not big burden to follow them. So it's once per year, clinically, biochemically, and magnetic resonance imaging. This is how we work in our center.
Okay, so you would propose MRI for your patient every year for a for the pancreas and probably for gallbladder or biliary tree.
Magnetic resonance imaging is the best method because computed tomography, due to the radiation, of course, is not acceptable, and we work as a team. So it's a team decision here that it's most appropriate for our cohort. Of course, it may be center depending. So if there are some centers that have a big endoscopic ultrasound team, this is also something that is acceptable, but endoscopic ultrasound is an invasive method. So we think that non-invasive method, radiological imaging, is more appropriate.
But let's get that straight to my understanding. So
and would you do, excuse me.
Sorry, I cannot hear you. Can you repeat once again?
Sorry, just to get that clear in my head. What is the purpose of the MRI? You want to exclude malignancy, because basically the indication for treatment of autoimmune pancreatitis would be symptoms. And what you're recommending would be that asymptomatic patients should undergo MRI once a year. So what is the underlying reason to suggest that?
It seems that just like I showed in the presentation, it seems that the risk for cancer in this group of patients is higher. However, due to the low number of patients, because we talk about orphan disease and rare disease, we are not sure about that. Since the current guidelines did not specify clearly how it should be done, I said just that in our center, we are working like that. So we are following them once per year to see what is the natural progress of the disease. We also know that these patients develop atrophy of pancreas very quickly. So this is the reason that at least in the first few years, it is really necessary to follow that. This is what we think, and this is how we work. Also, recently published scoping review showed that after the 2 years, most of the cancers developed. And recently we had also a patient in whom cancer developed simultaneously with autoimmune pancreatitis type 1. So just to avoid misunderstanding, this is how we work in our center. Guidelines recommend follow-up, but did not specifically indicate the timeline of following. So this is what we need a little bit more experience on this. So our experiences are based on our cohorts. 170 patients in 20 years is not high. So this is why, just like emphasized at the end, we need more studies on this topic to be sure what is the best follow-up method.
Just to complete, and after we move on, but do you distinguish type 1 and type 2?
Yes, of course, absolutely. We are absolutely trying to do that. However, small group of patients is not possible to differentiate. It's not out of specified, but most of our patients, approximately 90%, are clearly differentiated.
Okay. So we will have to move on. So thank you very much for your presentation.
Thanks a million. So we are now going to move on to our next speaker, and that's going to be Enrique de Madaria from Alicante, Spain. And he will talk about autoimmune pancreatitis, where are we now? And remembering his perfect or very interesting talk on the waterfall study yesterday afternoon, I'm very much looking forward to your talk, Enrique.
Hi, I'm Enrique de Madaria. These are my disclosures. Okay, we are going to talk about autoimmune pancreatitis. This is a rare disease. Data from Japan talks about an incidence of 1.4 for every 100,000 inhabitants, with a prevalence of 4.6 every 100,000 inhabitants. Most of the autoimmune pancreatitis from Japan, 96%, seems to be type 1 autoimmune pancreatitis, but this is a disease that is very well known in Japan, so maybe there is better diagnosed than type 2, but in Europe, type 1 is more frequent, but we have 20% type 2 autoimmune pancreatitis. Mean age is 68. The clinical presentation in type 1 autoimmune pancreatitis is an elderly male with painless obstructive jaundice, weight loss due to pancreatic exocrine insufficiency and diabetes. 80% had IgG4 autoimmune cholangitis, and it's frequent that other organs are involved. In type 2 is female or male, are younger, around 30, and the clinical picture is abdominal pain, acute pancreatitis followed by jaundice, and is more frequently associated to inflammatory bowel disease. Okay, type 1 autoimmune pancreatitis is associated to extra pancreatic involvement, almost 40% to salivary and lacrimal gland involvement. This is called Mikulicz disease, to hypothyroidism, to sclerosis, cholangitis, 60%, to pancreatitis, autoimmune pancreatitis type 1. If you take this organ as the source of most diagnosed cases, most of them have pancreatitis, interstitial nephritis or membranous nephropathy, retroperitoneal fibrosis, autoimmune hepatitis, interstitial pneumonitis, and hilar lymphadenopathy. There is an association between autoimmune pancreatitis and inflammatory bowel disease. Less than 1% of patients with IBD have autoimmune pancreatitis, but 30% of patients with autoimmune pancreatitis have IBD. And as we said, type 2 in most cases. This is a retrospective study, 91 patients with IBD and autoimmune pancreatitis. 2/3 had ulcerative colitis, 1/3 Crohn's disease. Okay, this is the pathology of autoimmune pancreatitis. It's important to differentiate between type 1 and 2. Type 1 is characterized by lymphoplasmocytic sclerosing pancreatitis. You can see here periductal lymphoplasmocytic infiltrate. This is very characteristic storiform fibrosis, this kind of fibrosis with this curious pattern. Obliterative phlebitis, you can see here a vein which is inflamed with arteries which are less involved than veins. And you can see the most important feature, periductal IgG4 positive plasma cell infiltrate in immunochemistry. Okay, the type 2 is the idiopathic duct-centric pancreatitis or granulocytic epithelial lesion or GEL positive pancreatitis. You can see here the periductal lymphoplasmocytic and neutrophilic infiltrate and the destruction of small ducts and ductal epithelium and lobular lymphoplasmocytic and neutrophilic infiltrate. There is periductal and intraepithelial neutrophilic infiltrate destroying the ductal epithelium, often with intraluminal microabscesses, and this is the famous granulocytic epithelial lesion or GEL, which is characteristic of type 2 autoimmune pancreatitis. And in immunochemistry, you can also find positivity to PDL1. Okay, these are the differences that we have mentioned before about type 1 or type 2. And there are biomarkers for type 1, as you all know, IgG4 in blood lacks sensitivity and specificity, but is helpful according to the European guideline on IgG4 related digestive disease by Matthias Lohr and colleagues, which is very important in autoimmune pancreatitis. These guidelines is highly recommendable for you to read it. It is recommended if type 1 autoimmune pancreatitis is suspected. The higher the cutoff you choose, the better specificity, but sensitivity will be low. 10% of patients with pancreatic cancer have increased plasma IgG4, and I have seen in my real clinical practice, patients with pancreatic cancer who had increased levels of IgG4. So be careful, my friends. There are other markers like antiplasminogen binding protein, peptide antibodies, antibodies to carbonic anhydrase 2 and antigens, antibodies to lactoferrin, but the role of these markers is not very, the role for the diagnosis is has to be further investigated because the sensitivity and specificity of these biomarkers is low. What about imaging? Okay, here you can see, let me put this one. Okay, and the normal pancreas, this is an autoimmune pancreatitis, and you can see a narrowed duct that can be unique or multiple. It's very characteristic of autoimmune pancreatitis, a long stricture of the pancreatic duct without significant dilation upstream. A dilation upstream in a stricture can be due to cancer or to any other disease, but it's characteristic of autoimmune pancreatitis, and this is very important, a long stricture without significant dilation upstream. Again, it can be multiple. You can find extrapancreatic involvement if you have a type 1 autoimmune pancreatitis, and it's important, it's a very frequent involvement of the bile duct. Okay, also you can find in autoimmune pancreatitis hypovascular on pancreatic phase with delayed enhancement. This is very typical of autoimmune pancreatitis. You can see a rim-like hypoenhancement. There is a rim in the pancreas, outside the pancreas. This is very characteristic. And it's very characteristic a diffuse enlargement with delayed enhancement. This is highly suggestive of autoimmune pancreatitis. This is called the sausage pancreas. The problem is when you have a focal enlargement, and you have to be careful because you have to make a good differential diagnosis with pancreatic cancer. In pancreatic cancer, you will find that the Wirsung duct may be obliterated. The duct does not penetrate the mass because the mass is growing and is making a stricture of the duct, and there is upstream dilation, but not in autoimmune pancreatitis, as we mentioned at the beginning. Here you can see nodules in the peripheric cortex of both kidneys. In type 1 autoimmune pancreatitis, this is the renal involvement, kidney involvement. You can see concentric wall thickening, in this case in the ileal bile duct. This is the bile duct involvement in type 1 again. Marked thickening of the ileal bile duct again. Here you can see bile duct strictures in the ileal bile duct. These are the kinds of the types of bile duct involvement according to the European guideline. This is a Mikulicz disease. These are the dacryoadenitis there. This is one of my patients from my clinical practice. You can see the salivary glands, which are enlarged. The patient received corticoids and this disappeared and never came back up to now. This is a CT scan of a patient with retroperitoneal fibrosis. You can see this involvement around the aorta artery. What about the diagnosis? Diagnosis is not easy. It involves the full clinical history, physical examination, laboratory investigation, liver, renal, serum protein electrophoresis, complete blood cell count, IgG subclasses. Serum IgG4 has a specificity of 60% with a positive predictive value of 34% and is normal in up to 50% of patients. You have pathology, you know that to obtain samples from the pancreas is difficult unless you have a mass, but whenever possible, you have to make confirmation by pathology. Imaging, you can use CT, MRI, or ultrasound endoscopy according to spectrum of organs involved. And you can also use a PET scan to distinguish active lesions from fibrosis and to reveal asymptomatic lesions in type 1. Okay, there is also the possibility to take biopsies of the ampulla of butter, and sometimes it may be positive to IgG4 immunochemistry, like in this case, published in 2019. And you have the international consensus diagnosis criteria for autoimmune pancreatitis, published in 2011, when you have the criteria for definitive type 1 autoimmune pancreatitis, probable based on histology, imaging, response to steroids. We do not have time to comment all this, but you can see that this criteria tells you the different levels of evidence according to the findings in imaging, in ductal imaging, in serology, histology, and response to corticoids, and the same for type 2 autoimmune pancreatitis. This is a very important publication. I recommend again for you to read it. And the problem is that if you have a focal enlargement of the pancreas. Pancreatic cancer is much more common than autoimmune pancreatitis, and it's more probable, and this is my experience, to have an atypical presentation of a frequent disease like pancreatic cancer. For example, a pancreatic cancer, I'm going to give you an example. I had a boy, 16 years old, with a mass in the pancreas. The boy had increased IgG4 blood levels, and I thought it was an autoimmune pancreatitis because he was so young and the IgG4 was increased in blood, and he had a pancreatic cancer with 16 years old. As I'm telling you, is more probable if you find a pancreatic mass to have a cancer than autoimmune pancreatitis. And this is important, but sometimes you will find an autoimmune pancreatitis, a focal enlargement due to autoimmune disease. But be careful, my friend. The treatment, indications for treatment according to the European guideline are symptoms, persistence of pancreatic mass to rule out cancer, persistence of cholestasis in case of IgG4 related cholangitis, subclinical situations that could lead to severe or irreversible organ failure. And treatment usually is started with prednisone, 0.6 to 8 milligrams per kilogram per day, or equivalent, typically 30 to 40 milligrams per day. And you have to assess with clinical, laboratory, and imaging. In 2 to 4 weeks, it's important to have a baseline CT scan or MRI to compare before and after the steroids. And then you taper by 5 milligrams every 2 weeks for 3-6 months. Relapse is more frequent in type 1 autoimmune pancreatitis, 38%, type 2, 16%. And in case of disease relapse, you have to consider immunosuppressive agents like azathioprine, 6-mercaptopurine, mycophenolate, mofetil, etc. New corticoid treatment with or without low dose maintenance corticoids, or rituximab. Rituximab, you know, that is a monoclonal antibody that binds to cell surface protein CD20, B cells, decreases B cell population, precursors of disease-specific clonal plasmablast, and there is much more experience in type 1 autoimmune pancreatitis because this is the one that relapses more frequently. So, and this drug is specifically, it specifically addresses the pathogenesis of the disease. It's highly effective in inducing and maintaining remission. There are some concerns about safety with infusion reactions and severe infections, but groups like the French group of Vincent Reboux is using them a lot in the Mayo Clinic, and it's highly effective. If corticoids are contraindicated, ineffective, or in case of relapse, just think in using rituximab. We can conclude that autoimmune pancreatitis is an infrequent disease affecting the pancreas, and in some cases, in type 1 disease, other organs. Obstructive jaundice with or without acute pancreatitis is the most frequent clinical presentation. Diagnosis is not easy, it's based on the patient as a whole. Corticosteroids are the cornerstone for inducing remission. Some patients relapse corticoids, immunosuppressors, and rituximab and are then the options. Thank you very much for your attention.
Thanks a million, Enrique. Let's put the question on the chat first. So this question has already been asked after the last talk. And it's one of our colleagues who suggests that in every pancreatic mass, if IgG4 is elevated, steroid treatment should be commenced before a Whipple's procedure. So you just outlined very nicely that the likelihood of pancreatic cancer is much higher than autoimmune pancreatitis. And also we have the problem of autoimmune pancreatitis type 2. So can you comment on this suggestion?
In this, thanks, Julia. In this setting, well, if you have an elevated IgG4 in blood, you must see first how much elevated it is. The higher it is, the higher chances of having an autoimmune pancreatitis. In this setting, what I would do first is to make an ultrasonography fine needle aspiration, because you will have a 90% sensitivity to detect cancer. If this fine needle aspiration is and the IgG4 is highly elevated, I would do a test with corticoids maybe. In other setting, the probabilities of having the disease, I think, is quite low. I don't know what do you do centers, Julia and Vincian, that you have a great expertise on this, but I think the level of IgG4 may guide the corticoids, or of course, all the other clues that the duct penetrating sign, you have to see the patient as a whole, but I have tried several times corticosteroids, and this was a cancer, in fact. I don't know what's your experience regarding this.
So I would totally agree. I mean, even if there's also sampling error, I feel most confident after fine needle aspiration excluding pancreatic cancer. And in this situation, I would probably start corticosteroids. I would rarely start corticosteroids only on elevated IgG levels if there has not been another organ involvement, or say the patient presentation fits very nicely to the clinical picture. But I'm very much afraid of cancer in this situation, so I would go to a great extent to exclude it.
Fully agree.
Jan.
Yes, I would say that it's very important to highlight that imaging is really the key. And if you have doubt, I do agree that we can do a little steroid test just to see if everything it's clear with steroid. But as you said, it's very important to repeat imaging just after 2 or 3 weeks after treatment to be sure that the mass is not visible, or and you have no doubt anymore regarding cancer. So to be very to do a imaging procedure very fast after the beginning of steroid treatment.
So there's one question from David De Mauro asking, so congratulations to your talk. How long would you use steroids to induce initial disease remission?
We give 30 to 40 milligrams, but well, we check by weight, and then we use it for 4 weeks and then start to taper it, 5 milligrams per week. That's the recommendation in the European guidelines.
So what is your choice of therapy for maintenance or drug for maintenance? Like
we usually first we start by tapering the corticosteroids and see whether it relapses or not, and then if it relapses, we repeat the corticosteroids, and we decide if we give azathioprine, or in some cases very small doses of corticoids. We usually use azathioprine. There is no much evidence on this, but well, we use it that way, and because we have a lack of better evidence, and I have not used rituximab. I have no tried in patients with relapsing, with more than 2 relapses. I know you have experience on that, at least Vincian, because I read her papers, but I don't have experience in rituximab treatment.
I guess in the interest
Okay.
of time, we have to move on, or Bastian,
Yes.
I'm handing over
Thank you
to
very
you.
much.
Thanks, Enrique.
Thank you, Enrique.
Bye-bye.
Yes, we have to move on now to welcome Casper Overbeek from the Netherlands, who manage a great observational study in Europe. And I think he will present his results. And the title is Autoimmune Pancreatitis in Europe, Clinical Profile and Response to Treatment. Thank you very much, Casper.
Hello, everyone. Thank you for tuning in for my presentation with the title Autoimmune Pancreatitis in Europe, Clinical Profile and Response to Treatments. My name is Casper Overbeek. I'm a PhD candidate and a fellow in gastroenterology and hepatology at the Erasmus University Medical Center in Rotterdam, the Netherlands. I don't have any financial disclosures. And my project is the result from the PRESCRIBE study, which is a European retrospective registry for autoimmune pancreatitis. And this project is part of the Pancreas 2000 program. And of course, I didn't do this by myself. I had the help of an amazing team. You see their names here on the screen, the PRESCRIBE core group members. They're all amazing guys, and we all did this together to get this project going with the help of our mentors, Professors Leur and Roosendaal. So a big shout out to you guys. Let's dive into it. Short introduction. As we know, autoimmune pancreatitis is a rare disease occurring only in around 0.3 per 100,000 of the population per year. As a result of this, the guidelines for treatment are consensus-based rather than evidence-based, and the guidelines, they advise to give a prednisone induction dose in between 0.6 and 1.0 milligram per kilo body weight per day. In clinical practice, this usually amounts to around 40 milligram per day, which we then give in the high dose for 2 to 4 weeks. After this, it's advised to taper down gradually for a total duration of around 12 weeks out of fear that the disease will reoccur within this time if you taper down too fast. After this 12 weeks, you can choose to stay on the maintenance treatment or completely stop. Most of the knowledge we have on AIP comes from Asian studies, especially on the ones on treatments, and there's a bit of a lack of European literature. Treatments guidelines are not evidence-based because of the scarcity of the data, and we don't really know any differences about the effectivity of the treatment regimens. So for the PRESCRIBE project, we had several objectives, primarily to describe the clinical profile of European AIP patients, to compare the treatment effectivity of the different given treatment regimens, and to compare these two things to non-European cohorts, namely Asian and North American patients. Secondary objectives were to identify factors that were associated with successful remission induction and to compare steroids and rituximab for the treatment of relapse of disease. As I said, this was a retrospective data study. We performed this in 16 countries in Europe, involving 43 centers. Here you see the map of Europe with all these centers plotted out. So it's really a large study with a large number of centers participating. So truly a European effort. We included all adults diagnosed with autoimmune pancreatitis since 2005. We chose this cutoff for the year because before 2005, the disease was not very clearly defined yet. We included the type 1 or type not otherwise specified as defined by the ICDC, and we excluded those who had undergone pancreatic resection. And this we did because that will be a major confounder for the future effective treatment if half of the parenchyma is missing. We also excluded any type 2 AIP patients, and we then stratified the remaining patients on their treatment regimen. The endpoints for this study, they were the primary endpoint was the remission of disease, which can be divided in complete remission or partial remission. Complete being the absence of clinical symptoms and the resolution of radiological imaging abnormalities. And partial remission would be either one of those two. The secondary endpoint is the relapse of disease. So in patients who first achieve complete remission, would then get a recurrence of symptoms or radiological abnormalities. All right, let's dive into the results of the study. We have a total of 1,079 patients registered in our database, and we excluded 344. 107 did not meet the ICD-10 criteria after we strictly applied these to the whole cohort, and 19 had a probable or definitive type 2 AIP and were excluded for that reason. 148 underwent surgery. This means that the remaining 735 were included for analysis. On this slide, you're going to see the characteristics of the cohort. It's in a table. I will walk you through it. From the characteristics of the cohort, what was most noticeable for us is that the percentage of male patients is slightly lower than we know from other studies. So we had 69% male, where in other studies this goes up to 90%. Our patients were also a little bit younger, with a median age of 57 years, where in the literature you see that patients are more in their late 60s. And we had a 10% prevalence of IBD, where, for instance, in Asian patients, it is more or less 6%. The other characteristics are not so much different from what we already know. And also when we look at the symptoms, the most dominant ones being jaundice, abdominal pain, and weight loss. This is what we already know from the disease, of course. Then when we look at the radiological characteristics, there's parenchymal enlargement in around 90% and in around 30% of focal mass or narrowing of the main pancreatic duct, which is also as expected. 45% had other organ involvement and 60% had an elevated IgG4 level. And all these numbers are not that different from what we already know. Then the results of the remission induction treatment. We grouped our patients according to what treatment they received at the beginning. The big group, of course, being steroids in 86%. Only 2 received rituximab as first choice, and 95 patients did not get any treatment. So there's quite still a group of patients that were deemed to not need any treatment at the diagnosis. And when we look at the remission rates, we see that steroids had a complete remission rate of 72%, and a partial remission rate of 24%, resulting in a cumulative remission of 96% in the left column. Compared to Asian patients, the rate of complete remission is a bit lower because Asian patients, they have been reported to respond to steroids in closer to 90%. Although the definitions of remission are not the same in all the studies, the trend is that it seems to be a little bit higher in existing literature. When we look at the group without any treatment, there's also an 81% cumulative remission rate, which is interesting. So this may be a different type of patient. We also compared those two groups, and when we look at the ones who received steroid treatment, we saw that they were less often asymptomatic than the ones without treatment. So having symptoms was a reason to start treating, and also having more often jaundice, and also more other organ involvement, and histological confirmation of the disease was also a reason to treat with steroid treatment. And this all makes sense because this is also what is advised in the guideline. Then when we looked at the predictors for remission, we wanted to see, can we predict which patients are going to respond well to steroid treatment and which ones will not? We only found one factor that was actually associated with not reaching remission, and that's the IgG4 level. We saw that of the patients who had an elevated IgG4 level, only 66% reached complete remission compared to 76% of patients without elevated IgG4 levels. This is an odds ratio 0.6 in multivariable analysis, and we can also see this here in the Kaplan-Meier curve. So in the pink curve, the ones with elevated levels who had a lower complete remission rate. So these patients might also form a group that may need some closer monitoring during the induction treatment phase. Then the next slide, and this slide is probably the most important slide of this presentation. These are the results on the effect of the starting dose and the starting dose duration. Here you see a bar graph, and it's divided in 3 categories. On the left side, the starting dose relative to the body weight. In the middle part, the starting dose in absolute milligrams. And on the right, the duration of the high induction dose. So how many weeks did we give a high dose? Pink is complete remission, blue is partial remission, and purple is no remission. And on the left side, the darker color is the group without any treatment. And then to the right, in ascending order, higher dosages and longer dose durations. And when you look at this from a distance, you can already see that we don't really see a linear pattern where high doses are resulting in higher remission rates. So the lower doses and the shorter durations of treatment have similar rates of remission as do the more aggressive treatment regimens. And we compare this also for possible confounders. You can see them on the right side of the slide to correct for any possible differences and selection bias in who's getting what type of dose. But when corrected for this, we also do not see any statistical difference between these groups. And I think that's a very important message. We also looked at the tapering phase, the total treatment duration phase, and the total cumulative dose of steroids. And we had almost 500 patients who reached complete remission on the steroid therapy. And 9% of these patients had a quick relapse. So within 6 months of induction treatment, they already had relapse of disease. And we call this a tapering failure, resulting from the thought that if this quickly the disease is coming back, then probably we built off the treatment too quickly. And when we looked at within this group, we could not really see any relationship between the tapering failure and between how long there was tapered, or how high or how long the remission induction treatment was given, or the total cumulative dose. In other words, a slow taper did not result in less tapering failure. We did find that there were fewer relapses within 6 months if there was parenchymal enlargement at the diagnosis, and more logically, when maintenance therapy was given, because 4% of those under maintenance therapy had a quick relapse compared to 14% without maintenance therapy. Then we had 587 patients who ended up in remission. They were followed for more than 30 months, and 30% had a relapse after around 15 months of disease. And we can see that there's a difference between those under maintenance and those without maintenance. And when we look at how those patients were treated, we can see that 67% received steroids and 17% received rituximab. And these are two interesting groups to compare, and we can see that they have exactly the same cumulative remission rate. So when patients have a relapse of disease, both steroids and rituximab are a good option. Now I'm ending up at the conclusions of my presentation. First of all, we've seen that European patients are demographically slightly different from Asians and North American patients. They have a younger age, they have a bit lower male to female ratio, and IBD is more prevalent. In the other characteristics and the course of disease, they seem similar. IgG4 levels were identified as a factor predicting to an unlikeliness to reach complete remission. So those with elevated levels may need some closer monitoring. And European patients, they seem to respond slightly less well to steroid treatments. From the results in this study, we would recommend to treat with 0.4 milligram per kilogram per day. So this is lower than the current treatment guidelines with a minimum of 20 milligram. And we do not see that a taper of longer than 12 weeks is more useful. So we suggest a shorter taper. More aggressive regimens with higher dosages, longer treatment durations, etc., do not seem to be more effective. I would like to thank again the prescribed core group members. You see their names again on this slide. But of course, there were so many people who were involved in this study, and I need to thank all of them. Here you can see all the names of the people who are part of this study with all the centers, and everybody did an amazing job. Thank you so much for your dedication and your time and effort. And of course, thank you for listening to this presentation.
So thank you very much for this very nice study, and I know that it was a great effort. So just to begin, you propose some recommendations due to your conclusion. And what about a treatment to maintain the remission? Would you recommend something or not for maintenance therapy?
Yeah, it's a
regarding
very
your
good question.
result?
For this specific analysis, the maintenance therapy was not the objective, so we didn't dive into it in detail. But from the first data that we have on this, we do see that maintenance therapy protects from a quick relapse of disease, and that patients have a lesser recurrence of disease. So I think there is a role for maintenance therapy for low-dose steroid maintenance, but we don't have the detailed information from this cohort specifically on this.
Okay, so you would discuss for some patients some maintenance therapy.
Yeah, I think maintenance therapy could be useful, maybe not in all patients, but in a selected group of patients. For instance, those with higher IgG4 levels, because we saw that those are less likely to end up in remission. So maybe those are patients to keep on maintenance therapy. But again, we didn't identify the factors yet. They're not very clear on which patients to select for maintenance therapy. I think there's still a lack of knowledge on that aspect that we want to clarify. But yeah, especially if people are relapsing multiple times, then I would definitely consider maintenance therapy.
And what is the place for immunosuppressive treatment, not a steroid, but the other kind of immunosuppressive treatment, specifically for this patient, which have a lot of relapse? What would you propose? So would you start after 2 relapses or more, or just after the first one? Do you want to propose another steroid course before? So what is your opinion after this observational study?
Yeah, I didn't present, of course, the data on the patients that were treated with other medications, because we also had patients under azathioprine or methotrexate, but those are smaller numbers. Even in this large cohort, there's only a few patients treated with those, obviously because the guideline doesn't recommend it. I stand by the guideline that first choice is steroids, and you should always start with that. Even if people relapse for the first time, we see from this data that in the first relapse, steroids still results in a high remission when you treat it again with steroids. In that case, you could also consider rituximab, but I think still steroids could be the first choice. If you have patients who do not reach remission on the steroids or incomplete remission despite the treatment you've given, or when they get diabetes or they get other adverse reactions to steroids, those are candidates to maybe switch to rituximab. And I think that is now a promising new candidate, that the data that we have are positive, and that they result in a good remission rate. Because the patients that we do have treated with this, they had a really good response rate.
Okay, so we have a last question from the audience. So good morning. I would like to ask if you know what happened to the group of patients without any treatment that you mentioned and who had complete remission. Yeah. So is it a spontaneous remission? Probably.
Yeah, so the group without treatment, there was a high percentage who reached complete spontaneous remission. That's why we also compared those two groups. I don't know by heart their long-term outcome of that specific group. It's a smaller group of only 90 patients who did not undergo any treatment. So I don't know by heart how many relapsed, but there were several that relapsed, but less than the ones initially selected for treatment. So those presenting with a milder version of disease, without jaundice, without symptoms, they have a good chance of spontaneous remission and also a good chance of staying in remission.
Okay, so I think we have to move on because we are already a little late. So thank you very much, and congratulations for your study once again.
Thank you, Caspar. And I guess we're going to move on right now to one of your co-workers, to Marco Lancilotta. He's a fellow at San Raffaele Scientific Institute in Milan, and he's also part of the Pancreas 2000 program. And he will report on long-term outcomes from a large cohort of type 1. Marco, floor is yours.
So I thank the EPC for giving me the opportunity to present my results on such a great stage. My hope will deal with the long-term outcomes from our cohort of autoimmune pancreatitis patient follow-up at our tertiary care center in Milan. I don't have any disclosure. Autoimmune pancreatitis was first defined as a corticosteroid responsive disease with feature of autoimmunity in 1995 by a Japanese colleague. And just a few years later, Dr. Amano, again from Japan, unveiled this remarkable association between elevation of IgG4 level and this benign form of pancreatitis. As you can see in the figure, the serum IgG4 level is higher in patients with this form of pancreatitis compared to other pancreatic disease. And it was just 2 years later that Dr. Kamizawa proposed this, that autoimmune pancreatitis was part of this new systemic entity named IgG4-related autoimmune disease. And indeed, IgG4-related disease is a fibroinflammatory disorder that can involve almost any organ system. And very recently, thanks to an international study, a classification into 4 different phenotypes has been proposed, each with its own peculiar laboratory and epidemiological findings. Here, there are the 4 phenotypes outlined: the pancreatobiliary disease, the retroperitoneal involvement phenotype, the head and neck limited disease, and the Mikulicz disease with systemic involvement. But it is important to underline that all the 4 phenotypes share the same histopathological feature with the storiform fibrosis and the IgG4 positive infiltrate. And autoimmune pancreatitis represents the most frequent manifestation of IgG4-related disease. It typically involves elderly males, and the most common manifestation is painless jaundice. What is remarkable is that this disease displays a great response to glucocorticoids and to anti-CD20 therapy, so rituximab, but in the short and long run, the relapses are very frequent. But to make things more complicated, a few years after autoimmune type 1 autoimmune pancreatitis discovery, was another type of AIP has been unveiled, and thus named type 2 autoimmune pancreatitis, which is a completely different disease with a completely different histopathology, which is characterized by neutrophil infiltration in the form of granulocytic epithelial lesion. There is no clear male predominance, and patients are usually younger, but there is still a great response to glucocorticoids. Despite these steps forward, there are still many questions that remain unanswered, especially in the long term. So it's not clear the role of the difference between these 2 types of pancreatitis and the role of maintenance therapy, and especially the impact of treatment on pancreatic endocrine and exocrine function. So to try to answer to these questions, we retrospectively review our cohort of AIP patients in Milan, having in mind these questions. So the difference between type 1 and type 2 AIP, and more important, the endocrine and exocrine function of the pancreas in the long run. As you can see here, in line with the available literature, patients with type 1 AIP are older and, of course, have higher serum IgG4 level. And not surprisingly, also they have a higher rate of other organ involvement, because, I mean, IgG4-related disease is a systemic disease. More importantly, more interesting, in type 1 AIP patient at baseline, there was a higher frequency of diabetes and jaundice. On the contrary, abdominal pain and acute pancreatitis were more frequent in type 2 AIP, whereas there was no difference in terms of pancreatic exocrine insufficiency at baseline. So there are marked difference between those 2 types of AIP. Moving on, about treatment strategy, in line with the available literature, glucocorticoids were the most commonly employed strategy, with the great rate of complete response. Above 75% of patients achieve complete response, similar in both the groups. And whereas maintenance treatment was employed more frequently in patients with type 1 AIP due to higher relapse rate. So about long-term outcomes, we observed just 2 relapses in patients with type 2 AIP in a follow-up of 1.5 years. So we will not focus on this group anymore, but we will focus more on type 1 AIP, where we observed 23 relapses in a time span of 2.5 years. And let's see how these relapse distribute compared to maintenance treatment. As you can see, 1/3 of the patient experience disease relapse in the maintenance group, and the contrary, more than half of the patient experience disease relapse in the non-maintenance group. And this translates, if we plot this over time, so in a Kaplan-Meier, this means that the relapse-free survival was higher in patients who received maintenance therapy. So in reverse, the relapse risk was lower in patients who received the maintenance treatment. So we can say the maintenance treatment does reduce the relapse risk. But then we decide to do another step and look for the impact of glucocorticoids-based maintenance treatment on the pancreatic function. So to do so, we focus on type 1 AIP patient, and we try to exclude some confounders such as patients who underwent pancreatic surgery, those who had diabetes at baseline, and we included patients who had received at least 4 months of glucocorticoid, having in mind these endpoints, so these outcomes, so diabetes, pancreatic exocrine insufficiency, and cholangitis. And as you can see, 1/3 of the patient with receiving maintenance therapy developed new onset diabetes compared to just 12% of the patient who did not receive maintenance treatment with glucocorticoids. So the diabetes-free survival was actually higher in those who did not receive maintenance treatment with glucocorticoids compared to those who received long-term glucocorticoids. Moving on, we did not detect a difference in terms of pancreatic exocrine insufficiency in both groups, meaning that 1/3 and 1/4 of the patient developed new onset pancreatic exocrine insufficiency, and regardless of the presence of the maintenance treatment. Last, we focus on infectious complication, and cholangitis is quite big problem in this patient because they are at risk due to the fact that the biliary duct is not very patent due to the extrinsic compression from the pancreas or due to concomitant cholangitis. As you can see, 1/3 of the patient developed in the maintenance group developed an infection cholangitis compared to just 5% of those who did not receive long-term glucocorticoids. So we can say that there is a higher risk of infectious cholangitis in the long-term glucocorticoids group. And overall, it seems that glucocorticoid-based maintenance treatment is associated with adverse metabolic outcomes. So where are we now? Dr. Overbeek just presented the results from the initial result from the prescribed study, and so we hope that this large cohort will help us in confirming or providing new results on the long-term outcomes of autoimmune pancreatitis patients, which are still not so clear actually. So to conclude, we see that there are marked baseline features between type 1 and type 2 AIP, and that maintenance treatment does reduce the relapse rate in the type 1 AIP patient, but of note is associated with a higher risk of new onset diabetes and infectious cholangitis. Finally, we for larger study are ongoing, like the prescribe, and we hope that they will provide us new information, new confirmation of these findings. So let me thank you, the colleague, gastroenterologist, pancreatologist working in my hospital, Rafael. Also thanks the Pancreatitis Group and the International Society of Internal Medicine. Thank you very much.
Thank you very much, Marco. Great talk. So before questions come in the chat, I'd like to ask one question. Do you think the sample size looking for complications of maintenance therapy was high enough in the two groups to depict relevant clinical findings? Did you redo a sample size? Because there were 22 and 19 patients, which is a very low number. Would you expect to see a difference there with regard to exocrine, endocrine insufficiency and cholangitis?
Well, I mean, this is a Great question, for sure. These are agreed. These are no big numbers, but these were the numbers we had. And as you see, I mean, the slides, we managed to actually find some differences in the relapse risk. And this is something in line with the available literature. And indeed, for the diabetes rate, we just saw a trend because the p-value was not statistically significant, but I do think that we might find something value with larger cohort. But I think that the values this work is that provide a concept that, I mean, we are still using the glucocorticoids and it's okay to use them, but we should be aware of the effect they have in the long term. So again, about using, I mean, this is in line with the using of immunosuppressor or moving on using biologic drugs. We should always have in mind that glucocorticoids are great therapeutic drugs, but they have such a huge burden of side effects, as also Miroslav said before, and also Kasper. So, but yes, I mean, the point is that we need larger numbers for sure.
As I don't see any question in the chat right now, I think in the interest of time, it's best to move on, and I hand over to Vinciane.
Yes, thank you. So we will move to the next presentation by Sarah Nikolic for autoimmune pancreatitis type 2 and inflammatory bowel disease. And it's a bicentric analysis and systematic review of the literature. Thank you.
Greetings from Stockholm. My name is Sarah Nikolic, and I'm going to present to you our research regarding autoimmune pancreatitis type 2 and inflammatory bowel disease. I'm a gastroenterology resident in Maribor, Slovenia, and a PhD student here at Karolinska. Please take a moment to acknowledge my co-authors on this project here. I have nothing to disclose. So let's proceed. We've heard that autoimmune pancreatitis is a rare disease, and type 2 autoimmune pancreatitis is even less frequent. Consequently, it's a challenge in terms of clinical research and follow-up of the patient. Diagnosis is not straightforward. Thankfully, we have international consensus diagnostic criteria since 2011 to help us. Within those criteria, other organ involvement described in type 1 AIP is not described. It's not a characteristic of type 2 AIP. However, association with IBD has been established previously and acknowledged within those criteria as a other organ involvement, actually, as you can see here. So up until now, to date, it's unknown if the diagnosis of IBD changes the natural course of autoimmune pancreatitis type 2 in any way. So our aim was to investigate the nature of the association between IBD and AIP type 2. This was an exciting collaboration with the Pancreatic Center in San Raffaele Hospital, Milan. We did a retrospective analysis of medical records and a systematic review of the literature. We defined exposure as IBD diagnosis as per ECHO and ESGAR guidelines. The primary outcome was the incidence of relapse. The secondary outcomes were clinical differences in clinical characteristics. Then in sub-analysis, we stratified the exposure according to the onset of AIP into IBD before AIP, which is IBD-B, IBD concomitant with AIP, IBD-C, and IBD after AIP, which is IBD-A. Results now. So there were 35 patients in our bicentric analysis. 83% of them had IBD. Out of those, 62% had ulcerative colitis. The median follow-up was 54 months. In the systematic analysis, we included 33 articles. 14 were from Europe, 9 from Asia, 4 from USA, and 1 from Australia. 693 patients had autoimmune pancreatitis type 2 48% of them had IBD. The ratio between ulcerative colitis and Crohn's disease was similar as in our cohort. So, in terms of our primary outcomes, there were no differences between AIP patients with or without IBD. Relapse rate was around 20%. Also, the rate of clinical remission was high, around 90 to 100%. The differences were in terms of clinical presentation. Autoimmune pancreatitis patients type 2 with IBD presented more oftenly with abdominal pain and acute pancreatitis, whereas those without IBD presented more oftenly with jaundice and as incidental finding. Also, in terms of imaging, those without IBD had only focal enlargement, and with IBD, both diffuse and focal enlargement. Among all those characteristics, the only statistically significant difference was in the prevalence of abdominal pain, and in the fact that autoimmune pancreatitis patients with IBD were more oftenly treated with steroids, whereas those without IBD had more surgical treatment. The prevalence of diabetes mellitus and pancreatic exocrine insufficiency at diagnosis and during follow-up was not different between those two groups. So when it comes to our systematic review, actually there was not enough data in order to compare the outcomes of autoimmune pancreatitis patients with and without IBD. There were no previous studies on that. However, we could compare the clinical characteristics and treatment strategies between our cohort, our bicentric analysis, and systematic review. And as you can see, the proportions, the prevalences were similar in acute pancreatitis, jaundice as presentation, and in treatment strategy with surgery and watchful waiting, and in relapse rate. The only difference was in the prevalence of steroid treatment, which was significantly higher in our cohort, probably due to the higher proportion of IBD patients. Then we performed this sub-analysis I talked about in the method section, where we stratified the exposure, which is the diagnosis of IBD, with regard to the onset of IBD. And we observed some interesting things, such as autoimmune pancreatitis as as presenting symptom was more common in IBD concomitant to AIP and IBD after AIP than in those patients before AIP. Weight loss, on the other hand, was more common in IBD after AIP in comparison to the other two groups. Pancreatic exocrine insufficiency at diagnosis was most common in IBD patients before AIP and IBD patients concomitant to AIP in comparison to the other group, and diabetes mellitus during follow-up was most common in IBD patients who had concomitant, or in other words, AIP patients who had concomitant IBD. So, to conclude, clinical and radiological remission of autoimmune pancreatitis type 2 is high. Cumulative incidence of relapse was around 20% in both systematic review and in our bicentric analysis. We observed that concomitance of IBD imposes no obvious risk for a different disease course of AIP type 2. And it is important to think of AIP as a differential diagnosis in IBD patients with unexplained GI symptoms. Thank you very much for your attention.
So thank you very much for this presentation. I know that autoimmune pancreatitis type 2, it's quite rare, so it's not so easy to have a large cohort. So I would have a first question regarding the rate of relapse of patients who had IBD and autoimmune pancreatitis type 2. You say it was around 26%. So the question is regarding the treatment. Sometimes, so that's my experience. So patients we are have already treated for IBD usually have less symptoms for pancreatitis, or if they have so, and you introduce a treatment for IBD because they have they get symptoms for IBD too. We can see that even if it is anti-TNF or so, it treats very well pancreas. What is your opinion? And so for patients, we get IBD before or concomitant IBD with autoimmune pancreatitis. What about the treatment of patients we get relapse?
Thank you for your question. I agree with you. Well, actually, you were one of the authors who published the article on that. So we also have patients who have anti-TNF therapy, both infliximab and adalimumab, due to IBD, and I believe they do not have any relapses of AIP, but we do not have the experience of treatment AIP with those substances, with biologics in terms of anti-TNF inhibitors, without the collaboration and the IBD diagnosis, if you know what I mean. So we never introduced by ourselves to AIP patients just because of the relapse. But I agree, it could be a promising treatment option, especially when it comes to pathophysiology of the disease and and the connection with IBD.
Yeah, because we are, I think that's my opinion, but I think that AIP type 1 and 2 are two completely different diseases and probably different physiopathology. And we do that. We perform one time for one patient with AIP type 2 without any response after steroid and rituximab, and I do treat the patient with anti-TNF inhibitors, and it goes very well without any IBD, I mean. So and that's why I wonder if you get the same things for one
well,
of
we
the
have the
patient
feeling, we didn't show the sub-analysis, but we get the feeling that the patients who have concomitant IBD and are treated successfully with anti-TNF inhibitors have a very peaceful AIP, but we never introduced by ourselves. It would be exciting thing to do, maybe on a pan-European level, to make analysis like that, firstly retrospectively and then prospectively, you know.
And what is for me very interesting is that patient with IBD, not with many symptoms, I mean, just treated by 5-ASA, I mean, FIV-ASA or Pent-ASA and so. And if you treat the IBD, so with very not immunosuppressive treatment, very small treatment, so the pancreas symptoms disappeared completely. So that's I think that we have to do something in a large cohort, European one. Could be very interesting.
Very interesting, yes.
So thank you very much for your effort, because we know that it's very rare disease. So congratulations. So we have to move on. Thank you.
Thank you.
So thank you very much. So we come to our last talk in this session, and that's going to be by Marco Tagelli. He's also from the San Raffaele Scientific Institute in Milan. So he's a co-worker of Marco Lancilotta, and he will give us a talk on the incidence of endocrine and exocrine insufficiency in patients with autoimmune pancreatitis at diagnosis and after treatment. Matteo, we are very much looking forward to your talk. You're misspelled in the program, by the way.
And I would like to thank you for the invitation and for giving me the opportunity to speak about our meta-analysis regarding the incidence of endocrine and exocrine insufficiency in patients with autoimmune pancreatitis at diagnosis and after treatment. I have nothing to disclose, and so let's start. Autoimmune pancreatitis is a process phlogistic that affects pancreas, but also can affect other organs. And it can affect both the function of pancreas, the endocrine one and the exocrine one. Various hypotheses were made in order to explain this, this problem. And the first hypothesis was that during the active inflammatory phase of autoimmune pancreatitis, the inflammation and the edema cause the loss of function of pancreatic cells. During the course of the disease, after treatment, on the other hand, we have that after this treatment, when the acute phase pass, usually there is a pancreatic hypertrophy that causes the loss of function of cells. Clearly, this is an hypothesis, and this was not proven anyway. The second hypothesis was that during the inflammation, there is a high amount of inflammation that is localized into the isolates. And this is proven by these articles that show that there is a high amount of IgG4 stain and IgG4 cells in pancreatic isolate during the active inflammation. This high amount of inflammation brings to the reduction of beta cells functions, and so to the glucose tolerance impairment. Also, this is an hypothesis, and we have no paper regarding the real reason for glucose intolerance and also to exocrine loss of function. Anyway, during last years, a lot of articles were published regarding this this topic. Some articles were directed to explain to investigate this specific topic, and other articles instead were more generic in order to explain the long-term outcomes of autoimmune pancreatitis. Anyway, this high amount of articles brought to a high heterogeneity. In fact, there is an incidence of pancreatic dysfunction that remains controversial and largely varies among different studies. This is also underlined by the European guidelines on IgG4 published in 2020, that in one statement says that the prevalence of diabetes in patients with type 1 AIP at the time of diagnosis widely ranges from 21 to 77%. Furthermore, we have to explain better which is the role of glucocorticoids that represent the first line of treatment in patients with autoimmune pancreatitis. In fact, there are few studies that reported an improvement of glucose levels following glucocorticoid therapies. On the other hand, we have also that there is a worse glycemic control in patients with autoimmune pancreatitis on long-term treatment with glucocorticoids. In particular, these are articles from Eastern countries that are those countries that typically perform long-term steroid treatments. In order to bring a little bit of order in all this amount of information that we have from these studies, various and heterogeneous, we performed this meta-analysis that has the aim of determining the prevalence of endocrine and exocrine pancreatic insufficiencies among patients with autoimmune pancreatitis at time of diagnosis and during follow-up after treatment with glucocorticoids. We performed a systematic research using these three platforms, EnBase, PubMed, and Scopus, and the research was during the all last years until August 2021. We also performed a quality assessment using a modified version of Newcastle-Ottawa scale. This meta-analysis is based on PRISMA guidelines, and it is according with it. Passing to the results, we identified 440 articles at the first research, and after the application of inclusion and exclusion criteria, we found that 62 articles that could be includable in the meta-analysis. 32 articles were give us only information on baseline data, 7 articles only information on follow-up data, and 23 articles both on baseline and follow-up information data. Among these studies, we found that there were 55 studies on the baseline for a total of 6,522 autoimmune pancreatitis patients. The baseline characteristics of these patients were various and heterogeneous. So we found that according with the type of studies, 38 studies were single-center retrospective, 10 studies were multi-center retrospective, 4 were single-center retrospective, and 2 were multi-center prospective with also 1 randomized control studies. Dividing the articles for the site of the study, 18 studies were made in Europe, 5 in the USA, 31 in Asia, and 1 was on multiple countries. The median length of follow-up ranged from 16 to 74 months. And one thing that we have to care about is that 15 studies enrolled less than 30 patients. The Newcastle-Ottawa scale found that 55% of studies were of low quality, low or medium quality. This was due fundamentally because of the absence of a guideline-based definition of diabetes and pancreatic exocrine insufficiency declared into the studies. And these were 45 studies. In 9 studies, there was an inadequate follow-up length that we defined of less than 24 months. And in 45 studies, we found that there was an absence of guidelines. The overall risk of diabetes on the plot of this meta-analysis was 36.5% of diabetes. But as we can see in this slide, there was a high amount of heterogeneity that is proven by the values of I-square, that was 96%. In order to explain this high amount of heterogeneity, we performed subgroup analysis, and we found that the variables that were significantly different in the various subgroups were the type of studies with a risk of diabetes in retrospective studies of 34% in respect to 55% in prospective studies. The risk was different also according with the site of studies, 44% in Eastern countries respect to 28% in Western countries. And also the publication year was very high, about 50% if the study was published before the 2010, and it was 32% after 2010. Furthermore, in order to better explain this heterogeneity, we performed also a meta-regression that didn't found variables associated with this high amount of heterogeneity. We also divided in the studies where it was possible, that were 20, the risk of diabetes mellitus in type 1 autoimmune pancreatitis with respect to type 2. In type 1 autoimmune pancreatitis, the amount was 44% of diabetes with respect to type 2 autoimmune pancreatitis, where it was only 11%. The exocrine pancreatic insufficiency instead was present in 45% of patients. And the predictors at the meta-regression of heterogeneity in this, to explain the rate of insufficiency was the concomitant high rate of diabetes. So, this could be explained by the fact that maybe the high amount of inflammation and the hypertrophic pancreatic parenchyma affects both the exocrine and the endocrine components in parallel, and was also related to the number of patients included in the study. This is a slide regarding the amount of diabetes mellitus and pancreatic insufficiency exocrine after treatment. And we saw that the number of patients with the diabetes mellitus after treatment was 43%, and the amount of patients with insufficiency, exocrine insufficiency was 39%. In conclusion, we can say that we provide the first comprehensive assessment on the prevalence of endocrine and exocrine insufficiencies in patients with autoimmune pancreatitis, that there is a variability in sample size and in the follow-up, so as a lack of systematic definition of exocrine and endocrine insufficiencies that might affect the accuracy of our quantitative analysis. And we also have to say that further larger prospective studies focusing specifically on the natural history of type 1, type 2 autoimmune pancreatitis are warranted to better evaluate the autoimmune pancreatitis and treatment-related metabolic changes in the long run. Thank you for your attention.
Thank you very much, Matteo. Are there any questions from the chat? We have got 171 listeners, but nobody is coming up with a specific question. So, well, let's be frank, in the interest of time, we should probably conclude the session at this point, because then we are almost in time and there's going to be a session on pancreatic exocrine insufficiency right after this session starting now. So then I would like to thank all the speakers for staying with us on this interesting session on autoimmune pancreatitis and the different aspects. So maybe everybody can show his or her face again, and we wave to our audience, and I wish you all a wonderful EPC meeting, and we hope for an on-site meeting next year in Alpbach.
Bye-bye, everyone.
Bye-bye.
I hope to meet you guys in person sometime.